Dr. Channa Amara-Sakera, or as we call him, Channa, is a Harvard-educated urologist. We're talking today about all those things that guys thought they would ask their doctor, but never did.
It's often the first sign of something that might be amiss in terms of someone's health. It can be the first sign of cardiovascular disease.
Not that you'd know how that would be.
I didn't know where that was going to go when you said, let's compare.
No.
I was getting a little worried. Okay. You connect your brain to your penis, so the two heads are connected.
And two heads are better than one. Yes. Yeah. Do you have a take-home kit for that?
Yeah. I have no guilty pleasures because I own all my pleasures.
3 is enough, and all of that. I like the 3 one, but I'm not sure that that's clinically correct. We're filming today from the beautiful Arlo Wynwood. It's one of the newest hotels in the Miami Arts District. We're on the 3rd floor at Higher Grounds. If you are into art, into mural art, it's the place to be. My guest today is a physician who is rewriting men's health. Dr. Channa Amara-Sakera, or as we call him, Channa, is a Harvard-educated urologist. He's also an assistant professor at Northwestern University in Chicago, and mostly importantly, is the founder of the nation's first gay and bisexual men's urology program. He's a leader in his field. He is a teacher, a professor, a surgeon, and he's someone who believes that health is not just a checklist, it's your foundation. We're talking today about sex, about erections, about hormones, about aging, and about all those things that guys thought they would ask their doctor, but never did. So buckle up. Today's show is going to be real. Can I call you Channa?
You can.
Thank you so much. We were going to call him Mr. Smith, but that seemed a little too out there. But Channa, thank you. Thanks for being here. We appreciate this.
It's my pleasure. It's great to be here.
He's come all the way from Chicago to be here in Miami, not just for this show.
It was just for this.
Was it just this show?
It was just for this show.
Well, I appreciate it. So, Channa, let's rewind. When you were a little boy, what is it that you wanted to do? I'm guessing that game-changing urologist was not a crayon drawing on your wall.
Well, I don't know that I wanted to be a urologist, but I did want to be a doctor from the time I was a kid. I like science, I like people, and it seemed like a pretty good mix. I don't think that was ever in doubt. I really enjoyed it.
So where did you grow up? Tell us a little more about your history.
Yeah, I grew up in the leafy suburbs of Colombo, Sri Lanka, where nothing exciting ever happened. And then I left when I was 15 with my family. We moved to Maryland because there was a civil war in Sri Lanka. I guess that's sort of exciting. But we transplanted the whole family here in Maryland. And then I grew up in Maryland from the time I was 15 to 22 and then moved to Boston for a while.
Ah, very good.
Yeah.
Well, you've told us that you were at Harvard, surrounded by all those great minds and a lot of competition. Did that push you towards your goal, or did that steer you in a different direction?
It wasn't so much that it was competitive. It was a very collaborative experience at Harvard Medical School. They didn't have grades, so there was no competing for being the top of your class because everybody helped everybody else. I think what was most like the part I liked most about it was the other kids. They really pushed you. They were very smart and they were going to be on top of their game, and they sort of pushed you to do as well, so that you could be just as involved with everything that was going on. So it did help to be around other people who were very, very driven and motivated and smart. But it wasn't a cutthroat environment, which I think a lot of people think of when they think of like Ivy League schools. It was actually much more benign and collaborative. I think there were a couple of things that happened that pushed me in this direction of being a gay men's urologist. And that's because in your 3rd year of medical school, you get to rotate through these different hospitals and you rotate through different specialties. And it was immediately apparent that I didn't like medicine, and that means talking about problems and like the medical side of things, where you basically talk about what the problem isn't, you round on patients, you spend an hour talking about each patient, about what, something is, and then you finally come to a diagnosis. And then you treat it with medications and hope things get better. I don't have the patience for that. I just like to cut. And so the surgical subspecialties were amazing. I was just enthralled when I was in the operating room. It was exciting. You got to treat a
Have
problem.
scalpel will travel?
Yes.
Okay.
When in doubt, cut it out. No, I'm kidding.
There you go. Okay. A little scary, folks. But I'm sure you make the right decision. So
Yeah.
was that the aha moment that puts you into the trajectory to go into urology?
Not quite. It was the aha moment that made me realize I'm not cut out for like talking about problems. I enjoy just working with my hands and figuring out the problem and then just like doing something about it right away. And that was very exciting to me. But what pushed me to urology is I was in a very liberal institution, a very liberal city, and in my urology elective, there were a lot of patients who came, a lot of gay couples who came, and the counseling that they got was, it didn't really seem to be customized to gay patients, and often they'd be left thinking, well, none of that really applied to me. And they would feel a little bit alienated. And it wasn't because their doctors were homophobic or that, things that they didn't welcome these patients. It's just that no one really knew how to counsel gay patients appropriately. So I thought there is an unmet need here, and there could be it would be good to fill that need to help gay patients feel like, hey, someone's out there listening to them.
Which is great, because I can imagine, you get a husband and wife in one situation, it's completely different than two guys dealing with some of the similar issues.
Right.
So, and what's needed and what's the best course of action, right?
Yeah.
So is that the motivation behind this gay and bisexual urology program?
Yeah. I had the inkling that there was a lot that could be done when I rotated through the subspecialties. But with anything that's medical, you need to prove it. You need to get some data. You need to show that what you actually thought is what's happening. And so when I moved to Chicago for residency, I wanted to be in a program that had an academic center, a VA, and a county hospital. And so there were very few places in the country that did that. And I moved to Northwestern to be in that environment.
Why?
Because it's a very different experience. So if you're in an academic institution, it's like a very different sort of way to practice medicine. Everyone around you, it's really well resourced. Everyone around you is very smart. The patients are very educated. They come out seeking care from a big academic center. And it's different at the Veterans Hospital, where those vets, they rely on you to tell them what to do. And it's a very different experience. And you get a lot more autonomy, and the veterans really trust the person that's giving them care. So you get to be very good very quickly when you're entrusted in the care of these patients. And in the county hospital, I just really enjoy serving like the indigent community. I think that's like an experience that everyone should have that you don't get when you're at a big academic center
Sure.
a lot of the time.
So let's get straight to it. Erections.
Yes.
Why do they matter beyond the bedroom? And what does it... the problem with erections reveal about a man's overall health?
Yeah. It's often the first sign of something that might be amiss in terms of someone's health. It can be the first sign of cardiovascular disease. So if you think of the arteries that go to the penis, they're tiny. They're very, very small arteries. They're much smaller than the arteries of the heart.
Well, some are bigger than others, right?
This is true.
Yes, okay.
But even in the biggest case, it would be smaller than that person's heart.
Okay.
Yeah. So when those arteries get clogged off, people have erectile dysfunction, but it can take a lot longer for that to show up in someone's heart just because those arteries in the heart are bigger. So if you have signs of ED, it could be early signs of some kind of cardiovascular issue. So guys who experience erectile dysfunction in their 30s and 40s, it's really helpful for them to get to their primary care doctor and maybe have a cardiovascular evaluation to see if they're at risk for early onset cardiac disease. It can also be the sign of mental health issues, depression, stress, poor sleep, that sort of thing. And oftentimes, if you correct these things early, you can have a much healthier life and a lot more longevity. So there are a lot of different disease states that can present as erectile dysfunction.
So what's the difference then on a one-off issue versus a continuing problem?
Yeah. What you're describing with one-off issues is what's called psychogenic erectile dysfunction. And that's when someone gets really nervous or something happens and they can't get an erection or they have performance anxiety. And it's very normal and common for that person to have fear that this is going to happen repeatedly. And so that the next time they try to have sex or an erection, that's all they can think about. And of course, that doesn't help.
Yeah.
And so there are ways to sort of suss that out and treat that. And if the issue persists despite treating that psychological component, then it's a much more chronic problem that needs to be addressed. And you got to figure out what is happening here. Is it hormones, nerves, blood flow, a whole host of different things that could be contributing.
So when you're making those diagnoses, do you bring in other people, or is that all part of this program that you've set up?
Yeah, the initial screen, and guys are terrible at seeking healthcare. And so this is, if you talk about erections and, sex, they're much more likely to come in. So you might be their first point of contact when it comes to healthcare. And so you sort of bring them in and you would do the initial, or I would do the initial testing to figure out if there's something like their thyroid or diabetes or some other, screening tool to see if there's some other, problem that's causing erectile dysfunction. And if there is, then I get them plugged into a primary care doctor or a cardiologist, or I refer them to the right person who can handle that other problem that's not urologic.
Kind of the tip of the iceberg sort of story, right?
Just the tip, I guess.
Okay, just the tip,
Yeah.
yes. You mentioned about a lot of guys are embarrassed about performance or lack thereof. What's the question you hear most in whispers and the, kind of, well, maybe this is happening and da-da-da?
Yeah, I'd say the biggest question is this normal? And a lot of guys are embarrassed to talk about it with their friends or, with other guys. And so they come to you and ask, like, is this a normal feeling? Like, does this happen to a lot of people? And the truth is a lot of guys experience ED in their 30s and 40s and beyond. So it's not that uncommon. It's just a matter of figuring out what's happening and what can you do to fix that.
Since we have all these guys watching and they're not willing to talk to their friends or other about it. So what do you tell them when they first come to you and they're saying, hey, we're having performance issues?
Yeah, I'd say, hey, it's super, super common, and I'm glad that they're there to discuss it with me. And then it's a matter of figuring out what's happening. So the initial testing that we'll run are things like hormones, like is their testosterone normal? Do they have a prolactin issue, or some of the sex hormones like estradiol or whatever it is.
What's a prolactic?
Oh, yeah, sorry. That's a hormone that's made by your brain, and it could suppress some of the other messages that get sent to the testicles to make testosterone. So you may not have an elevated testosterone, which you need or normal testosterone levels, which you need for erectile function.
Is there like a benchmark of what's normal testosterone level?
Yeah, it's a really good question. The benchmark is so broad. Anything between 300 to 900 is considered normal, but you might imagine that's a very broad range. And so what's normal for one person may not be normal for the next. For example, let's say your levels when you were in your 30s, there were 800, and now you're at 301. You'd technically be in normal limits, but that may not be normal for you. So we often go by symptoms. Do you have like a lower level than what you used to? And are you symptomatic? Do you have low libido, erectile dysfunction, low energy, issues with weight loss, muscle gain, depression, motivation? These are all signs of low testosterone.
So if I'm getting more muscle, I'm going to have lower testosterone?
No. If you lose muscle, if you have trouble.
Good, 'cause I was going to say, God, I'm quitting the gym tomorrow. So that idea of building muscle and all can be helpful.
Yeah, so if you have low testosterone, it's much harder to build muscle. So if you do have a clinically documented, meaning your lab tests are low and you're having trouble gaining muscle, losing weight, you're depressed, have poor motivation, erectile dysfunction, low libido, those are all signs that maybe some testosterone replacement might be helpful in that case.
Do you have any pills with you? So interesting. So those are the kinds of symptoms people should come to you with.
Yes, that's one part of what we do, which is screening for hormone imbalances. But other things that you look for are they diabetic? Do they have a thyroid issue? And these are all correctable causes of erectile dysfunction.
So is there a number that you have, or like a percentage of guys that are 50 and older that are having erectile dysfunction issues?
Yeah, I'd say it can be as high as 50%. But in my practice, it's much more concentrated, just because if they have a problem, they come see me.
Right,
so
yeah.
there are a lot of guys 50 and over with erectile dysfunction. But it's in the general population, it can be anywhere from like 20 to 50% at that age.
So in other words, these guys that are having this issue, they're not alone.
They're not alone.
Okay,
No.
very good.
Yeah. So it's totally normal, Marty.
Okay, good.
Yeah. Yeah.
Concerned. Yeah, no, listen. So anyway, I've got to go to the gym after this. We're leaving early.
Yeah.
Anyway, I'm a social media junkie. And on Instagram, I have no idea why I get all these ads, but I do, for everything from hormone replacement to increased testosterone to this pill does this pill does that.
That's shocking. I mean, you're so virile. Why would they target you?
And I love you for that.
Yeah.
So, and I appreciate that. But, obviously they send it out to everyone.
Obviously,
so
yeah.
Listen. And this pill promises increased libido. This pill promises an increased erection. This pill will, you'll stay harder forever.
Yeah.
And then the other, the stories you hear, this guy got hard and he's still hard 4 days later.
Yes.
So
not good.
Yeah, probably. But,
Yeah.
So what about those pills? What are they worthwhile? Is it voodoo or what?
Right. The supplements are not regulated, so none of the supplements are FDA regulated. You really don't know what you're getting in the supplements, and some of the supplements actually have real medications in them. It just happens to be packaged in a supplement. So I generally don't recommend using supplements over the internet or like at a gas station, just because you really don't know what you're getting. But then there are, FDA regulated medications that have a lot of the things that the supplements have, but in a more refined form. So things like Viagra, Cialis, Avanafil, whatever, these are all drugs that you can ask your doctor about that are safe to use, or they'll, see if there are any contraindications to using it in your case. But they work really well, and they're well studied, and they're generally pretty safe. And oftentimes they're generic. So there are a lot of, I don't want to say predatory, but there are, some predatory companies that sell you a generic medication, and they say, well, this is great because you can come to see our doctors online and you don't have to go to a doctor's office, and we'll mail you these drugs, and it's $100 a month. When, like, for example, Cialis, you can get 90 tablets of the 5 milligrams of Cialis for no more than $15 or $20 at a pharmacy.
At a pharmacy. So it's not expensive to begin with. So don't take these other ones.
Well, the other ones.
Be careful.
Yeah. Be careful that you're not overpaying for like privacy, essentially. Because if you go to your doctor's office, all of those records are private. Like there are federal laws that prohibit your doctor from sharing them with
They don't put a sign on your back, Cialis is here. Yes, okay,
right.
Very good.
Yeah.
Well, let's say, we've got viewers that have decided they're going to take Cialis, or they're going to take Viagra, or whatever that longer one name was that you said. What should they experience? What should be different?
Oftentimes I'll put younger guys who come in who don't have any other risk factor. You've done the workup. They have no abnormalities. They're healthy young guys, and they just had this one instance where they had ED, and now they have, persistent issues with ED. And it's often psychogenic. Like I think in those cases, you've got to rule that out. So I do a couple of things for those patients. I'll send them to a therapist who helps them work around those issues that they have around performance anxiety. But I'll also give them a very short course of Cialis taken daily. So for 3 months, they'll take a very small dose of Cialis, and that just helps them get their mojo back. So it makes it easier for them to get erections. And then when they have that confidence of, yeah, of course this is going to work, you can get them off the Cialis and they'll continue to perform well. So what you can expect if you take the medication is like you'll have an easier time getting and maintaining an erection. There's going to be better blood flow to the penis, and it just is a little bit of a boost. Now, of course, there are some side effects, like with any medication. So the common ones with Cialis, Viagra, that sort of thing are heartburn, sometimes muscle aches with Cialis, and back pain, facial flushing, nasal congestion. Those are the common side effects, but it's pretty rare at a low dose.
And don't confuse those muscle aches with sexual acrobatics.
Right, yeah.
Yes, okay.
Yeah,
which
you
is
never
hard.
can tell. So you got to, be careful and kind of think back to what you did. To see
There
if
you
there's
go.
something
Yes, no. You need an adjustable sling.
I guess so, yeah.
Okay, yeah. And so all those good things, yes.
Yes.
And some of our viewers probably don't know what that is, but it's just as well.
Yeah.
And, it adds more
Google.
excitement for the rest of us. And let's talk about ejaculation.
Yeah.
The patient has a problem with ejaculation.
Yeah.
What does that mean?
Yeah. It can.
I know what it is, but what is that? What's the symptom?
Yeah. So I'll give you the birds and the bees talk.
Thank you. Okay, good.
Yeah. This, everyone needs it. There's a common misunderstanding that ejaculation and orgasm are the same thing. And there are two very different things. Orgasms is a sensation of like the euphoria or whatever great feeling that comes with an orgasm during sex. And for men, oftentimes that's coupled with ejaculation, where they ejaculate semen at the time of orgasm. And so a lot of people confuse those two things as being the same thing, whereas you can have an orgasm without an ejaculation and you can ejaculate without an orgasm. They can be two very separate things. So sometimes when people say, I'm not having an orgasm anymore, you kind of have to tease out.
Kind of define it.
Yeah, define it for them. Or say, are you not having an orgasm, ejaculation, or both, or what's happening? So there are certain drugs, as people get older, their prostates get larger, and they start taking drugs that help relax the prostate, but it also leads to what's called retrograde ejaculation, which is when they have an orgasm, but nothing comes out. And that can be very distressing for people because it's a dry orgasm. And for some, it's like, oh, great, no cleanup. It's much better. But you want to figure out where your patient is on that spectrum. Are they bothered? Are they not? And what's going on? So things like drugs like Flomax can do it, which is tamsulosin, or some other drugs that essentially relax the prostate. Sildosin can do it. So that's one type of ejaculatory issue. The other types is someone having premature ejaculation. So are they coming too quickly, or are they having delayed ejaculation where they're not coming quickly enough? So you're trying to figure out, what is the problem here?
So what is the right time for ejaculation?
Yeah, the average is about 7 minutes. That's the average person takes that long to get to a climax. But it often depends on how bothered people are. Like if it's 7 minutes and they want to last longer, then there are ways to make that happen for them. Are you interested in learning the ways?
Absolutely. Yeah. No, listen, so 2 hours later, we're still having fun.
Right. Yeah.
So, yeah.
You could.
And so what are those ways?
Yeah. There's behavioral techniques that people, they stop and start or, whatever. And sometimes that works pretty well, but there are medical ways to do it too. You can use delay sprays where you basically use a lidocaine spray on the penis and help desensitize the penis a little bit and helps people go a little bit longer. Or you can take a medication or like an antidepressant, basically, not because you're depressed, but just because one of the side effects is that it can get you to last longer. So there's something called Paxil that we commonly use. You can take it either every day or on demand before you have sex. And that'll make it so that you can't get to an orgasm till much later.
Wow.
Yeah.
CVS, Walgreens, they're going to have a run on this stuff after we talk here. Lidocaine spray, really?
Yeah.
Just a second, dear. I'm going to just, okay, good.
Well, yeah, you do it, 5-10 minutes before you have sex.
Oh, okay.
Yeah.
So,
and then you can wipe it off.
Prep.
It's kind of like prep. Yeah.
Very good. Different kind of prep than what we're usually listening to.
Right. We'll talk about that too.
Yes. We've talked about how to make guys last longer.
Yeah.
What if they, want to speed this up? And quite frankly, I got a train to catch.
Right.
Yeah,
that's a lot harder to
no pun intended,
right,
but yes.
Right. So you'll screen them for medications that might be doing that. So if they are on a antidepressant, like an SSRI, then that could be the reason.
Or if they're spraying their penis with lidocaine.
Hopefully they're not doing that, but yeah.
That anti-itch thing? Yes, okay, yeah.
I guess that's a problem. But there are some antidepressants that you could talk about that don't have that side effect. So things like Wellbutrin, or some of the newer medications like Viagra or Trintellix. These are not often thought about because, and that's not because psychiatrists or PCPs don't care. It's just that, it's not at the top of their mind to think of delayed ejaculation. They're really focused on their problem, which is antidepressant.
Well, and they may never bring it up because this is something guys don't usually talk about.
Right, exactly. Right. Yeah.
We've talked about testosterone levels a little bit, but there's all these ads, the clinics that are going to raise your testosterone level and all of that. And when you hear the ads, it sounds like more is better, kind of like bigger is better. Is more testosterone better, regardless of where you are?
More isn't always better. More can be more dangerous because testosterone is a controlled substance for a reason. If you give someone too much testosterone, there could be cardiovascular risks associated with it. Now, for a very long time, people thought that testosterone in and of itself was associated with cardiovascular risks, but more recently, we found that that's actually not true. There was a very large randomized control study looking at testosterone called the Travers study that came out a couple of years ago. And it showed no real increase in cardiovascular risks in people who took testosterone. So I think that fear has been pretty much allayed. The problem with giving someone a lot of testosterone when their body doesn't really need that testosterone is it can raise your levels of how thick your blood is, your hemoglobin levels, and that can lead to potentially heart attacks, strokes, and just sludging of your blood. So more can be more dangerous. The goal here is to figure out, are you symptomatic? Do you have the symptoms that we discussed? And are your levels actually low? And as you get older, so from the time you're 40 till forever, your testosterone just keeps dropping 1% to 2% a year. So it can be pretty normal for someone who's 80 years old to have a testosterone of, like 150 to 200, and they might feel totally normal. That doesn't mean you should, replace their testosterone to get them to 800 because that may not be normal for that.
So in other words, if you're aging and you're down to 150 and you're still able to have an erection, you don't need more testosterone.
Right. And testosterone in and of itself isn't going to give you better erections. So that's another misconception, I think. People think if I have erectile dysfunction and I just take testosterone, my erectile dysfunction will get better. And the truth is it'll help you feel better, but it's not really going to affect erectile function. Now, for that, you'll have to take something like Viagra, Cialis, and the testosterone will help augment your response to it. So the two together will work a little bit better if you've got low testosterone.
So is testosterone really working more on your head than it is working on your penis?
It's working on everything. I mean, it's a very potent hormone. So it's working to help you feel better, like in terms of your overall well-being. And for people who truly need testosterone, if you put them on testosterone, they'll often say it's like night and day. It's like I was living in black and white and now I feel like I'm living in color. So it could be very dramatic. But these are people who really, really needed that testosterone because their levels were low.
Oh, very good. Do I see in black and white or do I see in color? I don't know. We'll think about that. Yeah. No, listen,
well, you should get your levels tested.
There you go.
Yeah.
Good deal. All right. Very good. It's right after I get the lidocaine and the,
Right, but you got to test your levels in the morning.
Oh, really?
Yeah.
Why? Does it go down during the day?
It goes down during the day. There's a circadian
That's why people
pattern.
want to have sex in the morning. I'm always sleepy.
No,
Huh.
You're right. It's highest around 4 o'clock in the morning, which explains why people have more
Wake up
of an
in the middle of the
interest.
night, or
they're just interested in the morning.
People are out late at night. Interesting.
Yeah.
Who knew?
Yeah.
No, this is all good. Folks, is this great information or what? So stay up late or get up early. More than one way too, right?
Yeah.
Let's compare. Sex in your 20s versus sex in your 50s. Not that you'd know how that would be.
I didn't know where that was going to go when you said, let's compare.
No.
I was getting a little worried.
Okay, listen. And no, I don't want to do that because then, listen, I know yours is going to be a whole lot better. What's the truth? What's the changes that happen through those years? And what actually gets better with age? Remember, you're talking to an old guy.
Can you repeat the question? What gets better with age in terms of like sexual function? Or
we've talked about what's the difference? What gets better, between from your 20s to your 50s, 60s, and 70s?
Yeah, I think, people, like sex isn't just like a biological thing, right? I think as people get older, they start to realize there's much more to it than just like, getting an erection, having sex. So I think that gets better with age, where you find things that really, you connect your brain to your penis, so the two heads are connected. And
two heads are better than one. Yes,
yeah. So I think that gets better over time as people kind of figure out how to make it more pleasurable in the context of relationships and just like other ways to you basically mature as a person.
Mm-hmm.
Yeah. So I think that gets better.
Yeah, very good. I like to hear that.
Well, some people never mature, but
that's good.
Yeah,
but and let's see. Then there's another topic. You hear so many people that are online watching porn.
Mm-hmm.
I don't know anything about that, but some people do.
Yeah.
I've read about it.
Yes.
And does watching too much porn really affect your sexual prowess or abilities?
Yeah, it does. It's a very common cause of erectile dysfunction in young men in particular, just because consumption of pornography, just the expectations in real life are so different from what people, like, when they watch porn, they expect real life to be the same thing as what they see on porn. And it can be very hard for them to turn themselves on in real life. So it can lead to a lot of erectile dysfunction for that reason. So if a really young person comes in and they're consuming a lot of pornography and they've got erectile dysfunction, I often tell them, listen, try to stop or minimize pornography for a few months and see if that makes a difference. And oftentimes it does.
Really?
Yeah. That's not to say, don't consume any pornography. I'm not saying that, but if that's pretty much all you do, then that might be a problem when it comes to your sex life.
There you go. Watch the Marty Davis Show instead. There's no pornography on here.
Not yet, at least.
Yeah, believe me. Yeah, no, you're safe there. We've talked about these pills that, help erection, help ejaculation. What other things do you recommend to your patients that may help in their sexual life?
I think diet, exercise, so like weightlifting in particular, can raise your testosterone levels and just overall well-being. A good diet, sleep is often overlooked. And so sleeping 8 hours a night and sleeping through the night is super helpful. And then just a healthy outlook and in terms of relationships, if you're in a relationship, or it's just like your mental health overall gets overlooked, and that can also be really helpful. So just generally things that make people healthy overall can often affect erectile function.
Okay, so there is a reason to go to the gym, and there is a reason to eat your green vegetables and reduce the amount of red meat, and
and
seared foie gras probably isn't good, huh?
No, probably not. Well, I mean, every once in a while.
Every once in a while is okay?
Yeah.
All right, good.
Everything in moderation.
Well, that was last night. So how about stress?
Yeah, stress management is key for a lot of different things that are health related. Yeah, if you're stressed out, your body's not going to want to have sex. It's just one of those things that you won't really be in the mood for. So reducing stress can really help get you in a better headspace to be sexually active and have sex and enjoy yourself.
We've been talking a lot about medication and diagnoses, but you really told us before, you're in this because you're a surgeon. And so let's talk a little bit about what are the surgical procedures that you do? What are the issues that come up that you're involved with on the surgical side?
So for erectile dysfunction, the most common pathway, let's say someone's got erectile dysfunction, you start with them with medications. And so that's the way to go to begin with. And then they might choose to try something like a vacuum device where you put the device on top of the penis, you pump it up, and it brings negative pressure into the penis, and it pulls in blood. And then you wear what's called a cock ring or a penile constriction ring to keep the blood in. You take the vacuum off, and then that could be a way for them to have sex. The penis can feel a little bit cold or cool to the touch, so it's not particularly natural, and so that might be not something that people want to do.
I'm sorry, that's after you use the vacuum and the cock ring?
Yeah, because you're constricting the blood. It's not circulating in there, so it's just like going to be a cold penis, and that can be upsetting to a lot of people. They don't love it sometimes.
Yeah, and especially the person whose penis it is too,
right.
I think would be a little odd.
Okay,
good.
So that's one way to potentially help. And then you could do injection therapy where you put a tiny, tiny needle, like an insulin needle, on the side of the penis, on the shaft, and that brings in blood into the penis. That's what porn stars use, just because you don't need to be turned on for that to work. For medications like the pills, you still need to be emotionally or physically or visually or in some way turned on. But with the injection, it just happens. Like it just brings blood into the penis, and it lasts for hopefully 30 minutes to an hour. And so that's one way to...
Do you have a take-home kit for that?
Yeah. The first time you do it, you have to do it at your doctor's office because they have to figure out what dose works for you. Because as you might imagine, if it's too strong a dose, you'll stay hard for over 4 hours, and that can really damage the penis because it can scar things on the inside. So you want to dose it appropriately at your doctor's.
Not to mention, it's hard to walk outside the house like that.
Right. Some people might like it, but generally not recommended.
There you go. Okay.
If all that doesn't work, then you should start thinking about a penile implant, which is a device that you put inside the penis. And the ones we use now are mostly inflatable, meaning there's a pump inside the scrotum. And when you need to have an erection, you just feel for that pump and you pump it up about 10 or 15 times, and it brings in fluid from the reservoir that's implanted deep within you into the penis that has 2 cylinders that fill with the saline. If you're at the gym or you're showering, no one can tell you've got this device in. But on the inside, you've got this thing that gives you an erection 100% of the time whenever you want it.
So it's like you're pumping up one of your testicles and you get hard for that?
Yeah, 2 testicles, and there's a pump in the middle of the 2.
Huh.
Yeah.
I just envisioned one of those turkey basters on the side like this, and it pumped you
No,
up.
nothing on the outside.
Oh, okay.
Yeah, it's all implanted
that's
surgically. Yeah.
Very good. And well, let's talk more about that.
Yeah.
Is that something that is an elective procedure, or is that something that gets paid for by insurance?
Both. It's considered elective, but insurance will generally cover it. Medicare covers the procedure. Most insurance companies, if your insurance plan pays for erectile dysfunction, they will cover the surgery. And oftentimes, it's a same-day surgery. You go home the same day or the next day, depending on how your surgeon likes to do it.
Really?
Yeah. And you can use the device in 4 weeks after the implantation.
And then does that need replacement after a while, or?
Well, it's built to last forever, but the device malfunction rates, just because it is a mechanical device, it can malfunction. At about 10 years, about 85% of them work great, but 15% of them will need to be revised in some way.
So that doesn't increase the size, it just gives you an erection. Obviously, an erection is bigger than a flaccid penis, but...
Right, yeah. It gives you an erection, but it approximates what the size of your erect penis is. So if you pull, you can stand up and demonstrate this if you'd like. If you pull on the flaccid penis, if you pull straight out, it's going to approximate an erect penis in terms of length. It's pretty close. If you really stretch things out. And so at the time of surgery, you basically pull and really stretch things out, and you put this device while it's nicely stretched out. So when they pump it up, it looks very much like their erect penis. Yeah.
And it's a good test when you're meeting someone new. If you like a big person, you should say, just a second, can I just pull on this for a minute?
Okay.
Yes.
Yeah.
Okay, very good.
Why not?
And then, you bring your tape measure with you, you're all ready.
Right.
Yeah, no, I have a minimum standard. And interesting.
Yeah.
Okay, yes. You hear this at bars, what people like,
Right.
Some people like dark hair, some people like darker skin, some people like short, some people like fat. Thank God, some people like old. It's all good.
Yeah.
So maybe we should put that on the list.
Right. Some are growers, some are showers. And this is a way to figure out if someone's a grower or a shower. You just stretch their penis out.
Because, you'd hate to have a shower who doesn't really show, in case you're not into that. Yes, okay.
Right,
Which is, I know that's a whole other set of people too. So, and all depends on whether you're a giver or a taker, I guess, too. Right.
Right. Yeah.
And so anyway, I think all this is valuable information. And, I'm going home and writing all this down or take a copy of this. Listen, our second episode is going to be what happens after you had these procedures. So,
and there are some guys who are like, do not make me huge. Do not make me big. I just want to be an average size because, there's the Goldilocks phenomenon where you don't want to be too small. You don't want to be too big. You want to be just the right size.
I love that. The Goldilocks phenomenon.
Oh, Goldilocks.
Oh, Goldilocks.
Yeah.
Better yet.
Yeah.
Okay. I like that. And it's all about the little bears. Yes. Okay. Yeah. No, listen. So some of us are over 50. Some of us are a lot older than 50, but that's okay. How do you counsel them to stay vibrant and active and comfortable in their sexual life?
Yeah, I think, a lot of the things we talked about before, like good diet, a healthy diet, exercise, sleep, stress management, those are all good things to start with. And then if you need a little help, you would start with medications and test your hormones, make sure that all looks okay, and just get into it. There are a lot of hangups people have about sex and sexuality, and I think working through those for the people for whom that's an issue is important. And working with a counselor or a therapist is often helpful with that regard. But
So you've said several things. So is there one daily habit that you'd wish all men would do every day?
I would say exercise, just because cardiovascular health is like paramount to good sexual health. And so if you maintain good cardiovascular health, it's very likely that you'll be very sexually in a good place sexually, I should say.
And is that cardiovascular exercise, or is that weight training, or
a combination of both?
Okay.
So a lot of people will do cardiovascular one day, weight training the next, cardiovascular the next day, and exercise 3 to 5 times a week.
Well, now, we've talked about the Goldilocks phenomena. And what if somebody comes to you and says, I do want to be bigger because bigger is better in my mind. What are the options and what's the results?
If they've got something like Peyronie's disease, which we haven't talked about yet, but that's the curvature.
That's the curvy one. Yes.
Like the bent carrot that you might see on TV. That can cause penile shortening because there's scar tissue that forms on the inside. So if you think of the penis like a long, thin circus balloon that you blow up, and then a normal penis is going to be nice and straight and elastic. On the inside of the penis, there are 2 chambers that fill with blood, and they're covered with these nice elastic coverings. And if you have some kind of trauma, and oftentimes it's microscopic where people don't recognize that there was trauma, the body puts down scar tissue to help heal that tear on the inside. And for people with Peyronie's disease, the body doesn't really know when to stop putting down that scar. So it has an exuberant response to some tear, and it puts down a ton of scar on the inside. So now if you think of that long, thin circus balloon that you blow up, it's like putting a piece of duct tape in one part of that balloon and then you blow it up. So it's not going to expand out as far as it used to because there's this constricting band in the middle. And then it's also going to curve up towards that band because it doesn't, there's something that's blocking its expansion on one side. So it's going to curve and get shorter. So for people with that particular problem, traction therapy is helpful to get some penile length back. And that's when you put your penis into this device that looks like a medieval torture device, but it's not very painful. And it has springs that pull on the penis to get some length back. The one that I really like is called Restorex. It's out of Mayo Clinic. And you wear that 30 minutes twice a day to get length back. But if someone wants something surgical and they don't have Peyronie's disease, and there are things people do. There are fillers that people use on the outside of the penis. Those give girth, but might be a little squishy and feel unnatural, but it is something that people do. And then there's the Pneuma device, which is a silicone sleeve that goes under the penis. That's a surgical option that increases girth, but also, again, it may feel a little unnatural just because it's firm, there's a silicone sleeve under the skin that you can feel, and it doesn't really enlarge the head, so it looks like a penguin that's kind of fat on the fat on the shaft and thin in the head.
And it kind of waddles if you do it in the right moment.
Right,
Yes, okay,
yeah.
Interesting. Clearly doesn't fly either.
No.
Yes. Well, now, do you do those procedures?
I do not. I do the procedures for Peyronie's disease, where I straighten the penis surgically, and that oftentimes gives people length back. The cosmetic procedures to give a girthier penis, I don't do that because I haven't found one that it really works well. And oftentimes, like the silicone injections and stuff, they'll become lumpy over the course of several years, or the device that you implant, if you take it out, people will scar down really badly. Like there are people who are very satisfied with those devices. I just don't think, like personally, I just don't want to take that risk for people, because I don't like, it's hard to correct something when, like, if you put it in, someone doesn't like it, it's really hard to go back.
There you go. It's a personal preference.
Yeah.
You're going to visit Antarctica to see penguins, not in the operating room.
Yeah.
Okay, fair enough. No, well, I think that's good. Do you think the future medicine will be more personalized for every man now in this kind of way of handling sexual dysfunction, sexual prowess, and all?
I think so. I think everything in medicine is going to go to like a personalized type of medicine. Like, things are advancing so quickly that you can eventually, people be able to figure out what kind of genes do you have and which ones are more likely to cause, whatever it is. And there'll be like a personalized treatment plan for you based on what your genetic makeup is and what's going on in your own body. Right now, like, it hasn't happened just yet, because, if someone comes with erectile dysfunction, you try to figure out what the root cause is and address that. But pretty much everyone gets treated with the same algorithm that we talked about. You start with medications, then like vacuum devices, injections, and then an implant if they need it.
Surgical is usually the last.
Yeah, you can pick it at any point. If you decide, hey, I want surgery, that's okay. But there's no going back from surgery. It works really well. The people who get surgery, there's a 98% satisfaction rate when it comes to the penile implants. And the most common thing I hear from guys is, well, I should have done this a lot sooner. A lot of guys don't know about it. And a lot of guys are just hesitant when it comes to surgery, which I understand. But the people who get it, they're in a place where they really need it because nothing else is working. And then when they get it, it's life-changing for them. It's pretty amazing.
So what role does AI and robotics play in urology today or in the future? Right.
Robotics is urology was one of the first adopters of the robot, like the Da Vinci robot. And we use it for minimally invasive surgeries. We started using it for prostate cancer, where we remove the prostate robotically. But now any kind of major abdominal or surgery that includes the retroperitoneum, which is where your kidneys are, uses a robot. And so it's a minimally invasive procedure, and you can often get out of the hospital either the same day or the next day. And so it's pretty common to use robotics. In terms of men's health or sexual health, the robot isn't really necessary, because like everything is already external. There's no internal surgery being done, because the penis obviously
it's right there.
It's right there.
There you go.
Yeah.
Well, so you don't have to worry about being replaced by a robot.
Right. I mean, I think we're nowhere near having robots replacing surgery, but it can certainly augment surgery. Like because the way you do robotic surgery is you look into these eyepieces and then you basically use these controls. So it's like playing a video game. But as you might imagine, if you feed thousands of surgeries into this artificial intelligence, like machine learning tool, it can look at what went right in those thousands of surgeries. And then if you're moving your instruments in a way that looks like it's dangerous or is not going to work, it can alert you to something to help you
just be more accurate, basically.
Yeah,
right?
exactly. Yeah.
Oh, very good. So I hear it takes forever to get in to see a urologist. What's the story behind that? Are there just not enough people going into urology? Or is the demand so great? Or what's the reason for that?
Yeah, it has to do with an aging population. As you get older, almost every guy is going to need a urologist, and a lot of women too. And the time it takes to train a urologist, it requires it's intense. It requires 5 to 6 years of surgical residency. And so you can't really train as many urologists as you need because that's a resource intensive procedure or like a training. So there are people who want to become urologists. There's a strong demand for medical students who want to go into urology, but it just takes a really long time to train them. And there aren't enough spots, I guess, nationally to accommodate that.
Well, we need to work on that. So talk it up. Those of you who, like the area, it kind of is a good thing to go into, right?
It's a great thing to go into.
It's a great area to go into. I always kind of like to do a little fast take on question and answers at the end of every interview.
Let's do
so
it.
that we can kind of do that round to get to know a little bit more about you. And let me ask you this. Let's talk guilty pleasures. We're talking sex. Why shouldn't we talk other guilty pleasures?
Yeah.
What's your favorite food when nobody's watching?
I have no guilty pleasures because I own all my pleasures.
There you go.
My favorite food is pizza.
Ah, very good.
Yeah, I live next to something called Robert's Pizza in Chicago, and it's like the 6th best pizzeria in America, and I'm there maybe 3 times a week.
That is good.
It's very, very good.
And you only get the healthy pizza, I'm sure?
Well, yeah, sometimes I get a salad when I'm, feeling healthy, but
there you go.
Otherwise I get a pizza and I have a slice or two.
There you go.
Yeah.
Well, that's great.
Yeah.
Okay. And tell me the name again?
Robert's Pizza.
Robert's Pizza.
Yeah.
They're going to be a sponsor of the show after they hear this.
So
listen,
delicious. Yeah.
You want to see your favorite urologist? Go to Robert's Pizza in Chicago. Morning routine, meditation, coffee, emails. What do you do?
Yeah, I try to run in the morning. So I have a gym in my condo building. And so I get up, I run, have coffee. And I live downtown. So I have this sofa where I just have my morning cup of coffee and I watch the world outside for a few minutes. And it's really nice. It's
very good. How far do you run?
I run about 3 miles a day.
Very good.
Yeah.
We were talking health for just a second.
Yeah.
This is really personal for me because how much should, everybody talks about you should have 8,000 steps, you should have 10,000 steps, you should have 3 is enough, and all of that. I like the 3 one, but I'm not sure that that's clinically correct.
Yeah.
Is there some number, or is that just, once again, voodoo science?
Yeah, I think 10,000 was pretty arbitrary. I don't think that there's a number. I saw a recent study looking at 8,000 as a reasonable number, but it's like whatever you can do to get yourself moving. I think, some is better than none.
Right.
Yeah. And it's all calories in, calories out. So watching what you eat and exercising appropriately.
Yeah, because that exercise doesn't really counteract the calories that are going in well enough.
Right.
For me.
Yes,
Well,
no, I wouldn't have guessed.
Yeah, no, absolutely. Listen, that foie gras, that's a week long of walking. So, but anyway, what's the one place you'd like to disappear for a month?
Wow. Wait, I'm a little, I guess I don't understand the question. I'd like to disappear too, or I'd like that place to disappear for a month?
Oh, no, what would be a favorite place for you to go for a month?
Okay.
And be there without any distractions from the outside world.
Oh, well, I really love Provincetown, Cape Cod. Any place with a beach, I think, for a whole month would be amazing.
Very good.
Yeah. But the one place I'd like to disappear for a month would be the White House for 1 month.
There you go.
There's too much political drama, so it'd be nice not to have that for a
There you go. At least just not even hearing about it. I understand. If you weren't a doctor, what totally different career would you choose?
If I weren't a doctor, I would try to work at being a stand-up comic. So there's Second City, which is in Chicago. It's where all the great comics like Tina Fey and everyone from SNL, they graduated from Second City. And so I often go to their stand-up comedy nights. And these people are they're funny, they're quick-witted, and it looks like a lot of fun. I'm sure it's a lot of work for them to be up there and think really quickly, but I think that could be a lot of fun.
Well, you'll let us know what nights you're going to appear. We've got a bunch of people watching. We'll all show up.
Yeah.
So very good. Oh, that's great. Theme song for your life right now.
Theme song for my life. I'm trying to think of sitcoms that, I'd say maybe the one from Different Strokes.
Okay. I'm not remembering that. I remember the show, but now I'm going to have to listen to it.
Yeah. I'll give you a backup theme song that you can cut in here.
Okay, perfect.
Yeah. Golden Girls just hit, 50 years?
Oh, yeah.
Or 40 years. Yeah, 40,
Really?
I think. Yeah.
Wow.
Yeah.
Yeah, no, that's hard to believe.
Yeah.
And
Thank you for being my friend.
That's right. Oh, isn't that nice, everybody? Yes. All good. Dr. Channa, we've had some fun today, and you've dispelled some myths, which is great. Maybe given some guys some good advice, and also been a aha moment. I'm not alone with that, which is great. And also that, you've probably made some of us squirm a little bit with some of these procedures that you might do. And, and then others are squirming in a good way. So it's all good.
Yeah.
And so if you're listening today and maybe you're in your 50s, maybe younger, maybe older, and you've been afraid to talk to your doctor, afraid to share the concerns that you have, I think Dr. Channa has told us, talk about it. Get the advice that you need from a professional and know that you're not alone. So there's nothing to be embarrassed about. If we can talk about it here in front of all these people that are around us today, you can talk about it to your doctor. Get the response you need and turn stumbling blocks into stepping stones, so to speak, and enjoy life to its fullest. I'm Marty Davis with The Marty Davis Show, and thank you all for viewing. Thank you again, Dr. Channa.
Thank you for having me.